face for the game tonight. I don't want to know. Okay, I'm in denial. The Yankees won their wild card game and Aaron Judge, 52 home runs in a rookie year. Holy moly. All right, shut up, Jim. So we are on chapter 22, slide number 23. I love sports, I love sports, but one of the reasons I love sports is because I'm extremely ADD. When my wife and I are having a very good, long conversation, I'm actually looking at my phone part of the time. Why? Because it actually helps calm the chaos in my head. And she gets me, so I'm thankful for that. And she's just as much of a weirdo about sports as I am. So, all right, if anybody hears a score, BJ, and it's not a good score, please shut up and don't say it, okay? So, asthma, what's the deal? What do the arterial blood gases look like during a mild attack? I don't give a crap, okay? Maybe there's a little bit of CO2 elevation, maybe not. And I don't care about respiratory alkalosis. The bottom line is hypoxemia begins to develop as bronchospasm intensity increases. Okay? What's bronchospasm? That's just another way to say temporary bronchoconstriction. Okay? So, do you do skin testing for asthma? No. You do skin testing for allergies in young people. So, is it worth going and spending, $1,000 now at 56 to go get skin tested? I wouldn't recommend it. Okay, unless you have, eczema or something like that that actually is really debilitating. What's the whole point of skin testing? Well, here's the deal, guys. The overwhelming majority of cases of extrinsic asthma are directly related to being allergic to something. Okay, and if you're allergic to something, eventually you have airway response to that. Does that make sense to everybody? Okay. Bronchial provocation testing you generally don't do unless the clinic that you go to is attached to the hospital or to urgent care. Because if you put histamine into me, I'm clamping down that quick. Okay? And so what do you expect to find in somebody who's an asthmatic, who's got extrinsic asthma? Statistically speaking, more likely than not, it's from allergies, elevated WBCs, of course, and elevated eosinophils, so you need to know that, okay? So treatment. Now, listen. The best treatment, you have to avoid triggers, okay? If you can take all the steroid inhalers in the world, you can take Benadryl round the clock like I do, and you can take all kinds of other medications, and I take a number of medications. They don't do anything if you keep on being exposed to the triggers. So, all of the methods that we know are short-term. Steroid inhalers are long-term. There are some issues with some steroid inhalers, I won't say it. Just be careful, and I'm not ever discussing this, you guys can Google this. But if anybody ever prescribes Advair for you, look it up, okay? It's $400 a month. When the company that made it rolled it out, they gathered all their pharmaceutical reps and they said, I swear to you, it's all been revealed in the court, you guys are going to become the owners if the only thing you ever sell is Advair. As it turns out, Advair has some unusual side effects for a small number of users. And those side effects are basically you're breathing, but you don't realize that it's not actually addressing the long-term issues it's designed to do. So one day comes where you take an inhaler and it doesn't work, and you suffocate to death. And it can happen in young people, it can happen in old people. It is the drug of choice for nursing homes in the state of New Mexico. You got a little bit of difficulty breathing? Why do they prescribe it? I can't imagine why, because Medicare pays for it and a whole bunch of other carriers pay for it. And etc. Okay? Jim, you sound really cynical. Just wait till you've been in the healthcare profession. If you ever get insight, work in an emergency room for like a year on a Friday and a Saturday night. Work in an ICU or a trauma unit or a trauma step-down unit. And then we'll talk about how cynical I am. That's all I'm saying, okay? Because that's actually where you're going to see the stuff that people debate without knowledge in the press about what's really going on with healthcare in America, okay? So environmental controls, you want to remove allergens. So I've got a deionizer, Jim, is that any good? Keep the USC time going, that's all I'm saying, okay? Do they work? Air purifiers, notice I skipped that, right? So air purifiers, it's important if you have a swamp cooler. Swamp coolers are disastrously bad for people who have asthma, period, okay? You have to make sure that you keep the filters clean, which means what? You gotta continually change them, which can be super expensive if you have a unit that actually does its job. It's best to have refrigerated air, but then you have to replace the filters, which is also not a big deal. But none of that guarantees that you won't have an asthma attack. It's just things to do. Preventative therapy. So what's preventative therapy? There's a bunch of different kinds of preventative therapy and desensitization. So what's a standard fare? You give somebody a steroid inhaler to desensitize the airways so they're not reactive. Does that work? It definitely works for a bunch of people. It doesn't work for everybody, okay? Last year, my steroid, I've never had to take a steroid inhaler because I've been pretty well managed most of my asthma life. But last year at this time, when it was drier than, I don't know what would be a good metaphor, Hades, I guess, here. For a long time, and then we had all those fires and then all that amazing pinon smell in the air. Look, Jim's allergic to it. And I was like an idiot. I was running outdoors in the morning, and after 2 weeks, I'd gotten enough of that stuff, those particles in my alveoli, that I completely clamped down. Urgent care twice, and only because I knew the physician who was working those 2 times. And so I did prednisone, it didn't do anything. I got a steroid inhaler, so $280 a month for 5 months. Do the math, okay? And it worked like a charm. Benadryl, I won't tell you how many milligrams I was taking every 3 hours. Okay? And it was, those of you who had me for fall semester for some class, I mean, I could not breathe for like 2 months. Okay? So avoid the triggers. So this, I mean, we have all kinds of rain, which is really amazing for those of us who suffer from allergies and asthma. But the other thing is, it sucks. I love running outdoors. No way. I'm not doing it until like December. Okay? Why? What am I doing? I'm avoiding the trigger. That's the issue. Okay? How about going and getting, I don't know why I had that slide there, so forget. Okay? Should I go and do the immunotherapy? So here's the deal, guys. So that's the injections, right? If you do them, you start them by yourself, you have to do them for 3 years consecutively. It runs about $3,000 to $4,000 a year. And most insurance carriers won't cover a big part of it. Because they say, well, it's not necessary because you can get some dramatic relief. Okay? So do you do it? At my age, at most 30 to 40% of the people respond favorably, and that's only after having been on that stuff for 3 full years. Some people, I mean, a lot of people don't respond to it at all. So, what are you going to see? So we are in the obstructive lung disorder chapter 22. We're going to see this list recurs with almost every single disease process we're going to talk about in the obstructive disease process. So O2 therapy for sure, small volume nebulizers. Oh, like this, right? Yeah, exactly. Okay. Beta-2 agonists, there's a bunch of beta-2 agonists. So remember, when you cause vasoconstriction, what do you get? Bronchodilation, depending on what drug you're administering, okay? Steroids, of course. Leukotriene modifiers. So remember I said leukotrienes are those chemical mediators of slow anaphylaxis, okay? You always want to keep, hey, you have an allergy, respiratory allergy, you want to make sure that those babies are kept intact. So that's montelukast for the generic or singular. That's what that addresses. Mast cell inhibitors, like what? Benadryl, Zyrtec. I can go on and on, okay? So we're going to see for most obstructive pulmonary disorders, most or all of these drug interventions are what you do, okay? So this is a crazy slide. You don't really need to know this slide per se. So what does this do? This shows you where various drugs, various mediators, what they do, and various drugs, what they cut off. So I'm not testing you on this slide. If there's something that's on the slide that I talked about, you have to know it, but I'm per se not testing you on the slide. If you don't address with asthma, like I said last week, if you don't address triggers and you're always only doing symptomatic relief, you get airway remodeling, and once you've got airway remodeling, you can't go in and make that lumen any bigger. You just compromise your lungs for the rest of your life, and that's problematic, okay? So, acute bronchitis. So listen, there are two kinds of bronchitis that we're going to talk about, acute and chronic. Acute, anything can cause it, right? Bacteria, viruses, parasites, fungi, you name it, okay? What is it? It's a temporary inflammation of the trachea and the bronchi. But it's not just bugs that can cause it, heat. So, if you're native and you go into the sweat lodge, there are some people who have respiratory issues, and the sweat lodge is actually very bad for you. Especially if you don't have a Native American running the sweat lodge, which we will talk about. There's a guy that accidentally killed a number of people in Arizona. He was not native, didn't know anything at all about running the sweat lodge. You go into a room where there's a wood-burning stove. I love them. They look beautiful. I highly recommend if you have money to get one and keep one. Don't use it inside the house. Okay? Why? It's dry heat. It generates an enormous amount of dry heat and particulate matter. Okay? So that can bring about acute bronchitis. Any kind of smoke inhalation. So I stopped at a Walmart on the way home last night not to get circus peanuts. I stopped by to get some green onions and some fresh tomatoes. And there's a guy who's actually buying really healthy stuff who's just puffing away on his vape. Smoke inhalation could be anything, right? I mean, you can get bronchitis from virtually anything, okay? Inhalation of irritant chemicals. You're somebody who works in a salon. You work at AutoZone, or not AutoZone, Pep Boys, changing brakes and tires and putting batteries in, right? So, what's the pathogenesis of this? You inhale something, there's an inflammatory process. The goblet cells produce mucus because they've been irritated and they want to stop everything, okay? And what happens? Holy crap, the worse it gets, now I'm not saying you die from acute bronchitis, so no apocalyptic overstatement here. You can under certain circumstances, but relax, okay? So what does it say? We have loss of ciliary function. How the hell does that happen? Well, the more mucus there is, the more inflamed the tissue is, you'll end up temporarily paralyzing the cilia or accidentally sloughing them off. But it's acute, so if it gets taken care of, they grow back and things are happy. Does that make sense to everybody? Okay. What does it look like? A cough. Listen to me. Get rid of your mind the fairy tales. Well, if there's a productive cough, it means this. If it's not productive, it means that. That's bullshit. Okay? If you hear fluid in the lungs, those are indicators. But in terms of productive or unproductive, never, never, never base anything on that. Okay? Low-grade fever. What's a low-grade fever? 99.5, 99.9. If you normally are clocking in at 98.2 or 98.6. My demon child's regular temperature is, of course, she's from hell, right? So her regular temperature literally is 99.6. So she's got to get, 101 to her is what 100 is to most other people, all right? So substernal chest discomfort. You got a little bit of discomfort here. Why? There's a tickle, maybe a little bit of pressure. And often when you have acute bronchitis, you have a sore throat. And why do you have a sore throat? Because there's junk coming down from your sinuses. Now listen, there's another fairy tale. Well, I'm not congested because I can breathe perfectly well. So that means I don't have any postnasal drip. Wrong. Open up your mouth, do the tongue depressor thing, or like we all do now, right? It's the selfie with the flashlight. Right? Exactly. And you look and what do you see? Holy moly, Niagara Falls is in the back, right? Well, if it's yellow, it means bacteria. If it's green, it means virus. Bullshit. That's all fairy tale. It can be completely flipped. Yellow can be virus and green can be bacteria. Yellow and green can be neither bacteria or virus and be fungi. Okay? So you don't get rid of those categories. And if you work where people are working in those categories, God help you. Okay? That's all I'm saying. And then there's fatigue. Listen, anytime we're sick, there's fatigue, right? We're blowing a ton of ATP to activate the immune system to fight whatever the hell's in our body. Obviously, there's fatigue. Don't need to know that. You need to know that, but you don't need to write that down. Okay? So why do you do a chest x-ray? Hey, your throat's a little bit red, snot, strep, you got postnasal drip, you got a little bit of a hack. So why do you do a chest x-ray? Because sometimes in some patients, the presentation of acute bronchitis isn't really acute bronchitis, it's actually the initial stages of pneumonia. Okay? And pneumonia, you want to take care of right away. Treatment. So if there is a bacterial cause of acute bronchitis, then you give antibiotics. If there is no bacterial cause, or if you don't know, you shouldn't just willy-nilly take a Z-Pack. Okay? Because antibiotics, when you give somebody antibiotics when they've got a viral infection, you actually help get rid of good bacteria and the virus can spread. Now, I'm not one of those people, oh my God, we're overprescribing antibiotics. Oh my God, we're gonna get the super bug one day. Don't email me that stuff because I think it's BS, okay? So at least I'm telling you ahead of time, all right? Codeine-containing medications. Wait a second. You need to take a codeine-containing medication for a cough. You always want to avoid doing that. But if the cough is a hack and the person can't catch their breath and it's very disruptive to their sleep, etc., and they're getting sicker, only then would you do that. But you try Delsym first. If Delsym doesn't work, then you can try. Jim, what about Robitussin? Delsym's dextromethorphan. No other cough medicine works anywhere near as effectively as dextromethorphan. If that doesn't work, then you do the codeine thing. Why do you avoid codeine? Well, you don't want to get somebody addicted. Well, there's that. But it's not really the issue, right? Why? Because if you're coughing, and you're coughing a lot, you probably have a slightly lower O2 sat, right? You take codeine, I mean, if you're coughing all the time, you got no choice. But if you take codeine, what does that do? It's a respiratory system depressant. So you're actually helping to, you're getting rid of the cough, you're helping to lower the O2 sat, okay? Increase fluid intake. Here's the deal, guys, okay? You must drink. And fluid intake, wine and beer, right? No, okay? You gotta take a ton of water or whatever that is not sugar-filled. That's the key, not sugar-filled. But you know you need that every day anyway, okay? Avoid smoke. Right. Hey, sweet, I got my Z-Pack. Let's go get a box of Marlboro Reds. I'm doing it, I'm gonna be okay. It happens every single day, okay? Use a vaporizer in the bedroom, hot or cold. So bacteria, unless you heat bacteria, I mean, some live till 3,000, 4,000 degrees, but the kind that are normal, common, all die at about 165 degrees. The hot air humidifiers don't heat to 165 degrees because everybody would be suing the manufacturer, right? Bacteria under 165 degrees in water. What's good, Jim? Should I get that? Keep America going, okay? Do you have any hot air humidifiers? No. Okay. What about cool mist? So here's the deal. If you have a hack and you're coughing, especially at night, it's good to have a little bit of humidity. Okay. Right now we have so much humidity. Open the windows. Right. It's during the winter when it gets really cold. Does it get really cold here? No. Okay. So, I mean, I know some of you are just like, man, he is the devil. I'm wearing a parka another month, Jim. Lane. Okay. All right, chronic bronchitis, pause. Listen to me. One of the things you're going to encounter in healthcare, if you haven't already encountered it, assuming you're in healthcare, the patient hears what they want to hear. They never actually hear what you're telling them. Okay? That means never. Most of the time they don't. So, chronic bronchitis. This is a chronic obstructive pulmonary disorder. That's what COPD is. It's a type B. I'm doing type B first, emphysema type A, but the reason why I'm doing this one first is because it follows off the heels of acute bronchitis. There is no relationship between acute and chronic bronchitis. None whatsoever. Okay? Chronic bronchitis, so listen to me. You have to know these numbers. I'm going to test you on these numbers. The same way on the very first question in the exam that you guys took last week. True or false? Calcium influx requires energy. False! Goes down its concentration gradient. It's lucitropy and getting rid of calcium relaxation that requires the ATP, right? But I'm not going to ask you obviously. I'm going to ask you not obviously. So, how do you know somebody's got chronic bronchitis? Because for at least 3 months, of the year, for 2 or more years in a row, they had a recurrent cough of whatever nature. Wait a second. So listen, you might be able to rule out if it's an allergy asthma sufferer, okay? So you need a good medical history on the patient. But the bottom line is, if you got somebody who say, hey, dear John Doe, you were in here last year, weren't you? You had a cough, right? Yeah, and it's gone like all summer, if I'm not mistaken. Yeah. So what do? We gave you some Augmentin, which renounce. At least it keeps you going back to your healthcare provider, and your insurance company keeps on paying the agreed upon amount, and then eventually you have to take some big drugs, and then you feel like you get better. Okay, were you sick the year before that? You know, I don't remember. How long have you had this cough? Now, God, it's gone most of the summer. Uh-oh. Okay. Coughs come and they go. If you have a cough, and it doesn't mean you're like, you know, turning blue every time you cough, and you're coughing 12 of 24 hours a day, but you're coughing. If you're coughing for 3 or more months, 2 or more years in a row, you probably have chronic bronchitis. Okay? So here's what the patient hears. Oh my God. Thank God, I thought it was something serious. Guys, chronic bronchitis is a death sentence. Okay? Who usually gets it? Smokers. 90% of the people who get chronic bronchitis have been smokers. They might have quit 20 years ago. Just saying. Okay? So, who typically gets it? Females, twice as likely to get it compared to a male. And the usual presentation is right smack in the middle years of adulthood. 30s. Okay? Now, middle years of adulthood, I didn't say it's middle age, you're not middle age, or you're approaching middle age in your 30s, right? And if you're not there, you guys are all going to get there someday, okay? A lot of people who have chronic bronchitis also land up developing emphysema, okay? Has anybody here ever seen somebody die from chronic bronchitis? You have? Okay. Okay, so it's memorable, isn't it? They drown. Can't get the fluids out of their lungs. They literally drown to death. Okay? So when you go to buy your partner on the way home that pack of cigarettes or a cigar, or score a nickel bag, you know, for the weekend, remember that. Okay? Next, cigarette smoke, anti-smoking. Okay? Other people who get it are people who have repeated airway infections. Why? What does repeated airway? Anything that's recurrent disease does what? Inflammation. If you have constant inflammation, that puts you at risk for all kinds of serious stuff. If it's in the respiratory tree, it might put you at risk for chronic bronchitis. Make sense? Okay. There may be genetic predisposition. Jury's out on that. Inhalation of physical or chemical irritants. In Europe, and I'm not saying that Europe is so great. Europe has its problems the way we have our problems. Okay? And Europe can be amazing and just as racially and ethnically prejudiced as a bunch of people in this country are. Okay? But the one thing that they understand a lot of things in Europe that we don't seem to understand here. If you work in a salon, if you work as a, quote, beautician, close quote, in Europe, most of the countries, you're forced into retirement at age 50, and they actually give you a pension. Why? Because the salon products are going to kill you at some point. Not Mark Patho. I pay $50 just that you will walk through the door there. They're healthy. Next slide. Okay? So what happens is the inflammatory process, okay? That's the bottom line. Everything's the inflammatory process. And you get hyperplasia. Remember we talked about that for asthma. What's hyperplasia? You get new cells being made. What new cells? Goblet cells. To do what? Make mucus. How much mucus? A ton. Why? What's the only way, after we've gotten past the sinuses, what's the only way we can stop anything before it hits the alveoli? Mucociliary clearance. That's it. So, hey, we've got this irritant, got the inflammatory process happening, got to make more cells. What kinds of cells? Mucus cells. Those are the ones that are going to ultimately do that patient in, because you won't be able to get the mucus out. The more mucus you make, and remember, inflammation, healing. Inflammation, healing. Inflammation, a little bit of scarring. Inflammation, a little bit of scarring. Inflammation, a little bit more scarring. You guys got that? That's the inflammatory process in the body. Only here we're talking about in the respiratory tree. Along the way, you're making more goblet cells, so we have to reinforce, make a little bit more smooth muscle. So we've narrowed the lumens, and the lumens are narrowed. They've got narrowed permanently. You get mucus produced, you get mucus plugs, and then you can't get rid of the air. That's why it's an obstructive pulmonary disorder. It's so hard to get rid of the mucus that those poor people who have it, and they can't get the mucus out. But the mucus is doing what? It's not letting air out, which means what? Eventually you can't bring enough O2 in. Make sense? Happy times. So there you go. All that tissue gets bigger, and it narrows. In the process, it narrows the movement. Okay. Already talked about that. Oh, going backwards. Sorry. Wow, that's really weird. It only took me like 8 slides to figure that out. So these people have increased O2 demands. Obviously, they might not. They might not know that they have chronic bronchitis, and the only thing that brings them in is, doggone it, man, again, I'm sick at the same time of year, and that's when you find out. Or, it's gotten a little bit harder to actually go up the stairs. It's gotten a little bit harder just to go and do whatever, okay? That might be the tip-off. Now, I don't care about that. When you have mucus plugs, when you have obstructive lung disorders and air gets trapped for whatever reasons, when you have coughing to try and clear the mucus out, what are you doing? You're putting an extraordinarily high amount of pressure on the pulmonary vasculature, and that goes all the way down to the pulmonary artery, creating pulmonary hypertension, and eventually it puts strain on the right ventricle so that you can get right ventricular hypertrophy. Okay? So you can actually, somebody with, if they don't suffocate to death, and you've probably seen this where you work, Alicia, person's had heart failure. If the heart simply couldn't fight all of the resistance in the respiratory vasculature. Does that make sense to you guys? Okay. So what are the clinical manifestations? Shortness of breath. Listen, somebody's got a cough, ask. When is it worse? Don't lead them. Is it worse in the morning? No. So is there any time of day when a cough is worse? No, not really. Really, like when you go to sleep, it's not worse. You do the opposite, right? No, you don't come to think of it. It's when I get up in the morning that it's the most difficult. Ooh, bad. Why? Because you're making mucus from the mucus cells, from the goblet cells, but when you're sleeping, you're not coughing to hack them out, so it becomes tenacious and it's a little thick, and you get up in the morning and you feel like you've got to clear your lungs. Does that make sense, everybody? Yeah, that's a big ticket sign that somebody's got chronic bronchitis or might have it. Evidence of excess body fluids. So edema, okay? Why edema? Because if you have pulmonary hypertension and slowed blood and higher resistance in the pulmonary vasculature, the blood is slowing down, right? The right ventricle is having difficulty. Where does the blood from the heart come into? The deoxygenated blood, the right atrium that goes in the right ventricle, so you've got slowdown. Make sense, everybody? Okay.
What if you are coughing at night, like trying to, like what if it's at night and in the morning, let's just say?
Well, that could be a million things, Jerica. That's a good question.
Mm-hmm.
I'm only talking about chronic bronchitis right now, but maybe you have something else.
Okay.
It's not, so if somebody's coughing at night, it might be something else. If somebody's coughing at night and they're not coughing in the morning, you ask them, right? You gotta find out, when did you eat dinner? How much did you eat? What did you eat? Do you have paralysis? Do you have heartburn? what beverage did you drink or didn't drink, how much, etc. So all of that goes into it. Does that make sense?
Yes.
It doesn't mean that if you have chronic bronchitis, you're not coughing at night. It's just that it's pretty stereotypic, because what do we do at night? We're resting, our oxygen demand isn't that big, and we're laying down. And so there's not that big of a deal, there's not that much work. And so the mucus is accumulating, you get up in the morning, and you cough. Does that make sense to you? All right, good set of questions. Don't shoot the teacher, that's from your book, that picture, okay? So we call it the blue bloater. You get puffy with edema, okay? Shortness of breath. Cyanosis is always a late sign. So, when you look at the chest x-ray, what do you see? Extravasations. I love that word, okay? Yeah. The metal disrupted my spelling. What do you see? You see markings in the bronchi and some of the bronchioles. Why? What is that? Edema. Right? The tissue gets inflamed, you're going to see the inflammation. Okay? You're going to pick it up. And congested lung fields. Congested lung fields, yeah. Oh, they've got pneumonia. No. That fluid that's in there might be fluid leaking from the pulmonary vasculature from increased pulmonary vascular resistance. Okay? And mucus. Does that make sense to you guys? That's an ominous finding, guys. And then you have an enlarged horizontal cardiac silhouette. So, I want you to know that. Okay? Why? Because that's right ventricular hypertrophy. When you see that and somebody's been coughing in the mornings and they've had cough for 3 or more months, 2 or 3 years or more in a row, that's almost dispositively chronic bronchitis. Sweet! Let's go out to dinner. I only have chronic bronchitis. You have no idea how you're talking about, right? All right, so pulmonary function tests, normal total lung capacity, right, because you can inflate the lungs. Remember, with obstructive pulmonary disorders, you can get the air in, you just can't get it out, okay? So if it's early enough, you can breathe out, okay? Now here's the deal, as it's developing, your FEV sub 1, how much you can force out in 1 second, starts to go down. Why? Because the alveoli get inflated, but the air gets stuck because the lumen get narrowed and there's mucus plugs. Make sense? All right. Super important. For chronic bronchitis, you tend to see elevated arterial carbon dioxide concentration early in the disease. Now listen, why am I making a big deal out of it? Here's why. Because in emphysema, you don't see that. In emphysema, somebody's walking around with an O2 tank and they can't breathe at all. Believe it or not, their arterial CO2 doesn't go up till the very end of their disease process. Whereas with chronic bronchitis, that's a distinguishing feature. Sounds like a sexy test question, call me foolish, okay? Early elevated arterial CO2, probably not emphysema. Think chronic bronchitis. Does that make sense to you guys? Okay. I don't care about the decreased O2 because that's going to happen in all of the obstructive pulmonary disorders. Okay? Oh, atrial arrhythmias. Right. Why? Because you're putting the heart under strain and you're not delivering as much O2 maybe early on, maybe not, but you're sustaining higher CO2s, that makes cells unhappy. You guys with me on that? Makes sense to you guys? Okay. The other thing that's huge, secondary polycythemia. Listen to me. So somebody comes in, yeah, I've been coughing in the morning. It's a little hard to catch my breath, I hack a little bit, but once, it's just got to be the weather. How long have you had this cough? 2-3 months? Did you have it last year? Yeah. Did you have it the year before that? Don't remember. Okay, cool. You order a CBC. And what do you see? Oh my God, their hematocrit's up. Bingo. Why is their hematocrit up? Well, listen. This is a chronic obstructive pulmonary disorder. You can get the air in, but it gets trapped, you can't get it out. Ultimately, what does that mean? You're reducing volume where you can do O2-CO2 exchange, right? If you're reducing volume, what does the body do? Hey, I'm delivering less O2 everywhere. The kidneys pick it up, and the kidneys say, that must mean we need more red blood cells. So it releases erythropoietin, goes to the marrow, you make more red blood cells to create a greater carrying capacity for O2. Does that make sense to you guys? So if they don't die from heart failure, and if they don't suffocate to death, then what might they die from? Stroke. Pulmonary embolism, right? Heart attack. Brought about by what? Secondary polycythemia. Make sense to you guys? Okay, cool. Medication, it's all the same stuff that we talked about. So I'm not going to talk about any of the medications here. It's pretty much the same thing. You might do O2, short-acting beta-2 agonists, bronchodilators, cough suppressants. You got to be careful. You don't want them coughing that much, right? But the more you suppress their cough, the longer the mucus and the fluid remains in, it becomes harder to get out. It's a catch-22, okay? And steroids. Theophylline is, there's only one difference in the theophylline molecule from caffeine, okay? So you take theophylline, you jack somebody's pressure, and their heart's racing. You have to be careful how much you give because you create an oxygen deficit in the heart muscle if they have COPD, okay? So don't care about that slide. Management, quitting smoking. Jim, that's obvious, right? No, it's not. Sweet, I only have chronic bronchitis. Give me some res, we're going to the bar. Okay? Bronchodilator, obvious. Adequate rest. Doesn't mean become a couch potato, because that's bad. Why adequate rest? Because if you don't get adequate rest, you need ATP, but you got to breathe in a whole lot of O2 to make the extra ATP, and that's something you're having a hard time now with. Why? Because you can't empty your alveoli. Make sense? Okay. Physical reconditioning. Here's the good news. With chronic bronchitis, yes. With emphysema, what I'm going to say, you cannot do it. With chronic bronchitis, there may be vast tracts of pulmonary tissue that are okay. So you work the hell out of them to get them to do a good job. Okay? But you've got to watch, because sometimes those people desat right in the middle of exercising. And that's a 911 call. Okay? Emphysema, type A COPD, pink puffer. It's extremely unusual for somebody under 50 to get it. Oh, so this is an old person's disease. Slow up and killer. Okay? It isn't. Listen guys, the stuff we put in our bodies rarely have, well it depends what you're putting in your body, but you smoke a little bit of weed here and there. I'm not going to listen guys, if you're on medical marijuana and you need to take it, God bless. Okay, you take it. You're still at risk for everything we're talking about, but you take it, right? I'm not talking to that crowd. So you smoke a little bit of weed, and I'm a social smoker. I light up because it's so cool to put my lungs at risk for cancer and chronic bronchitis while I'm sucking down some booze. It just, it's a happening scene, okay? It takes time to do damage. The fact that you have no symptoms right now does not mean you're not doing damage. Sorry, okay? There's a famous saying, youth is wasted on the young. Right? Right. So you have all this passion and energy, and that's cool, but we go and we do really incredibly dumb stuff. Old people do dumb stuff too, so I'm not saying there's any wisdom at either end of the spectrum. Okay? But the stuff that you do to your body, the fact that there's no consequences right away, it's a fairy tale that your body can deal with it. But you feel invincible because you remember, hey man, I had a hangover, and when did I ever end it? Yeah. Okay, all right. So if it happens, if you have a positive diagnosis for emphysema in a young person, somebody under 50, why would that happen? So listen, I had during the summer a student in one of my classes who actually, her entire family suffers from alpha-1 antitrypsin deficiency. Some have it in the liver. The problem, the liver makes it. Some have it in the lungs. So alpha-1 antitrypsin, we'll talk about it when we talk about the liver in the digestive unit. But the liver makes this thing called alpha-1 antitrypsin. And alpha-1 antitrypsin, that's why you have to take care of your liver. What does alpha-1 antitrypsin do? So you go outside and there's a little bit of dust. Let's say a dust devil comes your way and, hey, what the hell? I'm from Chicago. I've never been in a dust devil, so I went through one. Okay, I mean, it was a lot less than I expected it would be, but it didn't. So you inhale some particulate matter. It goes into your alveoli, and the inflammatory process starts. Well, we don't want to get scarring and lung tissue destruction just for a few particles. So what happens? Our liver makes and releases alpha-1 antitrypsin, and it dials down neutrophil response. So we get a little bit of lung clearing, but not a whole lot, because it's just particulate matter. It's okay. If you have an alpha-1 antitrypsin deficiency, whatever particulate matter gets into your lungs, you have a full-scale war declared, okay? And that harms the tissue in the lungs, and that's the kind of patient that would get emphysema before 50. Okay, does that make sense to you guys? All right. Usually, emphysema is over 50. These slides never worked for me when I was in grade school. I was 6th grade. They actually they took us to the sanatorium. We saw pictures of people that had lung cancer and their lungs and stuff like that. And a group of us left and went and got. At that time, it was super easy to get liquor. Got liquor and cigarettes. I mean, it didn't scare me, all right? I don't have it here for scaring purposes at all. I have it here because it's so not cool to smoke. It's just really not cool. And you smell so nice after you smoke too, right? So, I don't care about pack years, although you guys should know for yourselves, okay? I'm not going to test you on pack years. So who gets emphysema? Smokers get emphysema. What about people who live in Beijing? Sky high. LA? Sky high. Why? The San Gabriel Mountains on the east block the air coming off the Pacific, and they trap all that junk that's floating around LA. Okay? I love LA. I'm not just in LA, but to visit, not to live and run outside and breathe every day. Okay, and then certain occupations, right? So if you're Service Master is a great organization and company, but it took them a long time to understand when they were sending their workers into flood victim areas to do remediation, to go in and do clear, mold clearing and everything like that. That you're inhaling all that stuff, and eventually that can predispose you to emphysema. Mining, welding, yeah, hell yeah, okay? Because the solder gets airborne, and you're breathing it, okay? So, when you smoke, we get alveolar inflammation, and eventually it happens over time. What happens with chronic inflammation? We get scar tissue buildup. And that's just that's a late way of saying we get collagen reinforcement. Does that make sense to you guys? Okay. So we get collagen reinforcement, but that's not where it ends. The neutrophils get activated, and we can't make enough alpha-1 antitrypsin to turn it off. Hey, lighten up again? Sweet! Pookie Kings! Fry like everything all the way down. Haven't you ever noticed, if you've gone, I haven't, and I won't ever, but people come out of there and you bump into them at like a restaurant or a bar, and I don't go to bars anymore. I stopped that many years ago. But I'm not a teetotaler in drink. I just do it at home or out of the realms where there are cool scenes and stuff. So anyway, shut up, Jim. So have you noticed people that, went to Hookah Kings? How can you tell? Because you're kind of talking like this. I kind of lost my voice. It was really good. Right? Oh my God. All right? So what happens is your neutrophils don't get turned off. The neutrophils become macrophages. They release all kinds of chemical substances that were studied in Patho 1 for the inflammatory response. One of the chemicals that they release is proteolytic enzymes. Proteolytic enzymes, right, digest proteins. So, hold on, let's see if I got a picture. There we go. So when we breathe out, when we breathe in normally, we inhale, and if it's tidal volume, you just, half a liter coming in, going out. We breathe in. The way we breathe out is the signal to breathe in ends, and then we have higher pressure inside, lower pressure outside. Air goes down its pressure concentration gradient, and we've got elastic fibers right around all the alveoli that help squeeze the alveoli down to size, and out goes the air. Well, when you're smoking, listen, Jim, I don't smoke 2 packs a day. I don't do weed but once a week or only when I'm stressed, or once a month or whatever. No two human bodies are the same. You won't know how sensitive your lungs are until shit happens, and then you'll know. But then it's reversible, okay? So what happens is the neutrophils release proteolytic enzymes. Those proteolytic enzymes digest the elastic fibers, and the alveoli take air in, but there's no more radial traction to contract. Why? The elastic fibers are deteriorated. They're junkyard material. So your lungs stay bloated the rest of your life. Which means what? The air's never coming out of there. If the air is never coming out of there, you do the equation in your head. You lost all that volume and that surface area for O2 CO2 exchange. Right, guys? Okay.
Possible.
Yes.
Okay. The bloated lungs. What would be the difference with, say, for instance, an athlete that they say how would be the capacity of lungs? That they have a larger lung capacity versus the lung staying.
Oh, larger lung capacity. Larger lung capacity is one of the reasons why you run and work out, right? You create larger lung capacity, but your lungs, it means your lungs become a little bit stretchier, but they come back to the right size. Here, they're not able to because you've got rid of the physical structure that helps them come back to the right size. Does that make sense, Andrea? Yeah, so listen. It's not cool to smoke, okay? I'm telling you guys, man, this is scary shit, all right? And if you've ever seen anybody who suffered, emphysema is a disaster. You've seen somebody die from chronic bronchitis. It sounds like they've got the death rattle, but that's how they live, okay? So let's go back to this slide. I'm not going to go through this. I've said essentially everything here. Remember when you light up this weekend, whatever you're lighting up, look at this slide, okay? So, what is it? It's an obstructive pulmonary disorder, which means what? You can't get the air out. Why? Because it got trapped in. Why did it get trapped in here? Because we lost radial traction. Make sense? Okay. Those are alveoli. They're complete. Well, Jim, that's just artifact from a slide. No, for any of you who had ANP2, and we're in the respiratory unit now in the labs. So you take a look at really good, healthy alveoli. They don't look like that. This is consolidation of the lung. They've been destroyed. They've been bloated. Why? Because there's emphysema. Can't exhale. So I already talked to you guys about this stuff. And then you keep making mucus. Notice, The alveoli are bloated, they're filled up, they're never gonna empty. The lumen is narrower, and we've got mucus. Fun times, okay? Guys, listen, I did not quit smoking until I turned 40. I smoked from age 7 to 40, okay? It was not a teacher, it was not somebody who's, not done the bad stuff. I've done it all. And this is bad stuff. Now, the good news is, if you quit smoking now, quit smoking. What does quit smoking mean? It means there's no social smoking. It means you don't have one this weekend, right? You quit smoking now and don't get cancer of the lungs for the next 11, or any of this stuff, for the next 11 to 12 and a half years. The good news is then that your chance of getting lung cancer or any of these things drops down to the same rate as if you were a non-smoker. So if you quit today, you guys are young, then you don't smoke for another 11 to 12 years. Jim, there's no one in the classroom that smokes. My nose can pick it up, right? I thought I would cover up really well. I'd come home, I told my wife, why did I quit smoking? Come home, hey, so, did you buy a new bottle of cologne to try and cover that disgusting smell up, Jim, on your suit? Thanks, honey. Oh, you're chewing that mint. Right, that convinces me. Okay. All right, I don't care the kind of emphysema, but there's a bunch of different kinds you can get. Guys, look at these slides. Woohoo! Light up! So, what does it usually show up as? Sadly, over time, how long? Who knows? It could take a long time, but people usually statistically say, I noticed the last 3 or 4 years I just don't have the energy that I used to, or when I'm doing certain things, I used to be able to do them really well, and they tire me out. Do you think it's my diet? Do you think I need to lose a few pounds? Do you think X, Y, and Z? You smoke? Oh, yeah, but not a bad amount. Just I'm a social smoker. How long you smoke? Well, it's not smoking, Jim. Answer the questions, right? So usually, the patient says that they've noticed that they are a little bit more out of breath. Okay. Often, the patient, if it's entrenched and they don't know it, they're thin. Why? Because they're burning up so much flipping ATP, doing the muscle work of trying to get just an extra cubic centimeter of lung volume to be able to take air in. And it can't, and that burns up a ton of ATP. So what does the body do? The body turns in on its stores and starts attacking the body stores to be able to make ATP. Does that make sense to you guys? Okay.
Does that have to do with the fact that you get your blood pressure goes up, like when you smoke? So
For what the
so you smoke, your blood pressure goes up temporarily. That would mean that you are needing more oxygen because you're not getting enough oxygen.
right. Yeah. Well, that's actually true. Every time you take a puff, your blood pressure goes up a smidge. Okay. But your brain is incredibly brilliant and stupid simultaneously. So as you smoke, you train your brain, the higher CO2 level is supposed to be okay. And then you got the other 2,000 to 4,000 products that are created by the interaction of smoke and the moist lung surface. So we've got all kinds, thousands of chemical reactions going on at the surface of the lungs. And all of that serves to cause neutrophils to show up and destroy lung tissue. Okay? So, pursed lip breathing. Shallow breathing, of course it's shallow breathing. Why? A lot of lung volumes no longer available because they're bloated, right? If they're bloated, what else does that mean? The chest is expanded, right? And the diaphragm is kind of domed down. which means that you lost a little bit of play in the diaphragm, which means even the diaphragm can't help you as much anymore. So you look at somebody, you look at their nares. Are they flaring? Do you see the scalenes and all the accessory muscles being used? Like that. And listen, nothing you can do when that happens. That's the best they're going to get for the rest of their lives. There is no reversing that. Okay? Well, I can go ahead. Again, don't shoot me. This is from your book. I could go ahead and get on a lung transplant list. Yeah, okay. Good luck with that. The lung transplants, and I said this 2 summers ago, and it's true. Statistically speaking, lung transplants usually are not very successful. And there were 2 people in the class that had neighbors that had had lung transplants like 10, 12 years earlier, and they were still living. So that's awesome. But that's a huge gamble. And if you got emphysema because you were a smoker, it's really hard to get that lung transplant. By the way, do people who have the O2 tanks, who have emphysema, do they continue smoking?
Mm-hmm.
Yes, all the time. Okay? Well, I made it this far. Oh, no, you didn't. Right? Minimal or absent cough. Why is there a minimal or absent cough? Because you can't bring in enough pressure air to generate the 100 millimeters of mercury that it takes to generate a cough. Make sense? Okay. What does that mean if you get an pneumonia, you get something else in your lungs? Right, you're screwed. That's what it means. Okay? All right. Decreased heart sounds. Why are there decreased heart sounds? Because you have so much air, you've created this huge kettle drum, basically. Okay? That's trapped in there. Oh, yeah. And you take an x-ray and you see a narrow, almost vertical heart shadow. Why? The lungs are bloated, they're pushing on the heart. But Jim, that means that hemodynamics are compromised. Yes, exactly. That's exactly what it means. Okay? Don't care about that. Chest x-ray, so we talk hyperventilated, low flat diaphragm. I don't care about the blebs. We'll look at blebs later, but those are malformations on the lungs. And if they pop, air goes out, you get atelectasis or collapsed lung. Okay? Narrow mediastinum or small vertical heart, talk to you guys about that. So listen, chronic bronchitis early on, elevated arterial CO2. Emphysema, you only see the elevated CO2 at the end. Okay? Arrhythmias, yeah, the heart goes to hell. Why? You can't breathe in. You got all kinds of extra pressure in the thorax that you're never getting rid of. And you can't meet oxygen demand. Okay? Treatments, the same thing we talked about. Oh, there are treatments. Yeah, guys, this is palliative care. Okay? It's not curing something. Bronchiectasis. Next one. So some microbe gets into the bronchial wall, and the bronchial wall gets infected, and it gets dilated and inflamed, and pus and stuff start getting released. Okay? So you see it more often in kids than in adults. Acquired, pretty rare. What does that mean? It's really hard to go out and get bronchiectasis. Most of the patients, so fully half of the patients that get bronchiectasis have cystic fibrosis. So what's cystic fibrosis? Okay. Actually, we talk about that here. Yeah, great. So with cystic fibrosis, we're going to talk about it a bunch of times. With cystic fibrosis, 1 in 3,000 roughly Caucasian births carry the gene for cystic fibrosis. And what is it? It's crazy. It means you either don't have any or you have very few chloride channels in your cells. That's it. But what does it mean that I have a chloride channel? Well, what that means is that that affects the direction that water goes. So when you make mucus in the respiratory tree, it's thick and tenacious like molasses. It's not loose the way it should be. Well, they can drink a whole lot of water. Yeah, if you have cystic fibrosis, that doesn't do anything. Okay? Because you don't have the flipping chloride channels. So you tend to make thick, tenacious mucus that traps the microbes. It festers, you get inflammation, and the wall gets infected. Okay? Now, if there's inflammation and the wall gets infected, wall gets infected, mucus production, right? You just narrow the lumen. You got air in, you can't get it out. That's why it's a chronic obstructive, and that's why it's an obstructive pulmonary disorder. I don't care about the kinds, but look at it. Jim, does this stuff actually develop all the time? Okay? So, recurrent infections, it's the same thing, right guys? So you get it once, you get inflammation in lung tissue, your body resolves it, yay, no problem at all. You have cystic fibrosis, it's happening often, okay? It happens often, what do you get? You get chronic inflammatory situation, you get scarring, you get decreased lumen that's long-term. So you have to diagnose this stuff right away and give antibiotics. So I'm not kidding you. So, you see, are you supposed to see this? Never. What are you looking at? Fluid. What kind? Some is water, some is mucus, a whole lot is pus. Okay? So the air can't get out. Ultimately, that means air can't get in, right? Okay? And these are actual alveoli that are just filled up because of bronchiectasis. Does that make sense to you guys? Okay. So listen, I don't mean to be vulgar, but how the hell do you know that your patient potentially, how do you suspect that your patient potentially has bronchiectasis? Their breath smells like hell. Okay? It's vile. Why? You can smell the pus from the bacteria and the festering in the bronchioles. Make sense? Yeah, exactly. Scary stuff. Okay? They do have a productive cough. I don't care about green or yellow. It smells like crap. Okay? They might have hemoptysis. They might be puking up blood. Why? Because this stuff eats through the wall. And remember, what's in the wall of all bronchioles? Smooth muscle. And they don't do their work unless they have oxygen, which means the capillaries deliver the oxygen. So as it's tearing away, you might be rupturing capillaries and puking out blood as well. Make sense? Okay. Fever and night sweats, yeah, I mean, obviously you got a microbe that's at work. Skin pallor, you look very, very, very pale. So my very precious oldest daughter, who is my middle child out of 5, picture texted me today. It's Dad always loves a picture from his kids, but she texted me today and she said, "Do you think I look a little bit more pale than usual?" And I said, and she's the fairest complected of all of us in the family. And I was like, "No, honey, you have a beautiful southern Mediterranean tan. Of course you look pale. You always look pale. You're parchment. You got the parchment gene, okay?" But in somebody who isn't normally like that, who is suddenly like that, why are they that way? Because the blood isn't carrying enough O2. That's why, okay? So I don't care about clubbing. I hate clubbing. I'm never going to test you on clubbing to help with clubbing, okay? No, it's a good measure. It's a good measure for respiratory problems, but you get clubbing for a bunch of other stuff. All right, why do you get malnutrition for bronchiectasis? Well, do you eat when you can't breathe? No, right? Okay. Recurring pneumonia. Yeah, if this stuff is festering, you don't necessarily ever completely get rid of some of the microbes, potentially. Does that make sense to you guys? Or you're just constantly vulnerable and susceptible to certain microbes, okay? Right ventricular failure, listen guys, anything that causes obstructive pulmonary disorder puts strain on the pulmonary vasculature, increases the pressure of the pulmonary artery, which potentially causes pulmonary hypertension, and can cause right ventricular hypertrophy. Makes sense? I mean, we've been through that a bunch of times now. So, diagnosis, well, it smells terrible, and they're coughing like hell, and it might be very productive when they come in to see wherever you're working. Their pulmonary function test, well, this is an obstructive pulmonary disorder, they cannot breathe out successfully. So you do the spirometry test, right? You blow in a spirometer, oh my God, you're at half capacity for your FEV sub 1. Make sense? Yes? Okay. So I don't know why I had a second thing. Yeah, I don't know. So antibiotics, obviously, for the obvious reasons. Bronchodilators, we always do that, right? Vigorous chest percussion and postural drainage. People who have cystic fibrosis have thick tenacious mucus, and they basically have to get their bodies beaten to get the mucus to get loose of the tissue in the respiratory tree. So you might see, especially kids now, a bunch of kids, thank God, get these vests they get to wear during school day that vibrate. And that helps to keep the mucus from sticking to the alveoli and the bronchioles, okay? Proper hydration and nutrition, right? Nutrition, so you can make ATP, so you can do the work of breathing. Hydration, in the event that you're one of the rare cases that who does not have cystic fibrosis, to loosen the mucus. So bronchoscopies and surgical removal, all I can tell you is those are usually very unhappy days. That's all, okay? Bronchiolitis. So itis, inflammation, bronchial, it's the small tubes in the respiratory tree, right? So what happens in bronchiolitis, there's inflammation of bronchioles, not in one region, usually a bunch of regions. It's a very fair and equitable process, okay? And it's almost always due to infectious agents. Now, it occurs winter to spring. Children less than 2 years of age. Those are the people that typically get it. Does it mean an adult can't get it? Oh, no, an adult can get it. If you're a smoker, smokers are predisposed to bronchiolitis, okay? If you are an immunosuppressed person, so whatever, you have some autoimmune disease and you're taking some drug for the autoimmune disease, what does that mean? Well, the rest of us are inhaling microbes, but our immune system deals with it, and we don't ever really know about it. But that isn't necessarily the case for people who are immunosuppressed. Why kids under 2 years of age? One, their immune library isn't sufficiently developed, right? The second thing is the respiratory tree is super narrow, so they're predisposed, okay? So viruses, bacteria, you name it. So what happens with bronchiolitis? Well, it's an obstructive pulmonary disorder. So what's the inflammatory response? Neutrophils come in, and we make more mucus. You notice there's a recurring theme, right? Probably for you guys when you're studying, you can go through all of chapter 22 and list down and notice that there are a bunch of common symptoms. So you don't have to memorize the symptoms for 30 or 40 different disease processes. It's an obstructive disorder. Here's what you're going to get. So production of mucus, and what does that do? That temporarily plugs up the bronchioles, so small tubes. If it plugs up the bronchiole, that means the air is not going to come out, right? What about some of those alveoli that didn't have any air, because we do recruitment, right, Jim? What about those that didn't have any air in them, and they're the ones that you have mucus plug in? Oh, well, no air can get into them, they collapse. That's atelectasis, okay? But for the ones that you can get air in, it gets stuck, hyperinflation, airway obstruction. Jim, this sounds like everything else you were talking about. Exactly. Okay? Notice here, release of chemical mediators, inflammation, goblet cell metaplasia, so we make more mucus, increased bronchial muscle mass. Why? Because when we make more goblet cells, we need to reinforce. So how do we reinforce the tissue? Collagen and smooth muscle. Make sense? It's literally the same damn thing that's happened with everything else we've talked about in this chapter so far. And that's really the point conceptually. And that's the study aid that you think about. There's nothing new here. Okay? So, what is it? Present like, so listen, don't get all tripped out. Kids get bronchiolitis all the time, they recover marvelously well, right? Can it be fatal? Yeah, it can be, but that's like really ignoring it for a while until you have atelectasis developing, okay? But you have wheezing and crackles, of course you do, because if the mucus isn't getting hacked out, where is it ultimately going? In the alveoli. Make sense to you guys? Okay? And decreased breath sounds, well, if you're hyperinflated and can't get air in because you're hyperinflated and you can't get it out because it's an obstructive disorder, why would you hear any breath sounds? It's already inflated. Does that make sense to everybody? Okay. Low-grade fever, yeah, because it's a microbe, right? Tachypnea, dyspnea, well, that's a no-brainer for all of these, right? They're pulmonary problems. So, great. And notice everything's the same, except that here we have sedation. So, I'm not suggesting that if you are responsible for a small child, that you ever administer liquid Benadryl to them. I'm not suggesting that right now. Have you done that, Jim? You know, sedation's a good thing when a child's anxious. That's all I'm saying. Okay? Guys, listen, if a kid can't breathe, when an adult can't breathe, an adult freaks out. Kid can't breathe, the kid really freaks out. Right? So you have to figure out if they're super anxious and they can't breathe, you're exacerbating the underlying pathology, you want them to get better. Do you go ahead and give them any medication for sedation? You'll learn your ways as you walk in this world. Cystic fibrosis. Okay, there it is, of course. Yeah, exactly. Thanks, Brianna, I appreciate that. No, exactly. So, Caucasians, listen, it's not a uniquely Caucasian. I mean, mostly Caucasians get it, but there are people who are not Caucasian who have gotten it. Which means what? Genes are really weird. That's what it means, okay? So it affects everything, can't make chloride channels. When you're talking about the digestive system, that's when we'll talk about the digestive implications. Here it's just a respiratory thing, and do you ever get better from cystic fibrosis? No. Do a statistically significant number of people with cystic fibrosis make it to 70s or 80s? No. It's a death sentence, still, okay? If you could figure out that a mom or a dad have the gene, at some point in the future, if we can alter the gene structure, yay. But until then, it's a death sentence, okay? So what do they get? Obviously, constant infections. Recurrent episodes of bronchitis because microbes get in, mucus gets made, it doesn't get released, it's tenacious, it stays in. A lot of urgent care visits, etc. Okay? So, unequal breath sounds. So, I mean, I don't care about clubbing. Dyspnea and tachypnea, of course, for all the reasons that all of these obstructive disorders give that to us. I don't care about sternal retractions. Obviously, when you auscultate, you can tell that there's stuff in the lungs. But unequal breath sounds. Why? Conceptually, because it doesn't do it symmetrically. That's the reason why. Okay? Does that make sense to you guys? If you have somebody who's young, anywhere like 30 or under, okay, and you don't have any reason to suspect that they're hiding a physical injury or anything like that, abuse, that they don't have like lung cancer because they're young still, whatever, and they have a productive cough and they've had recurrent bronchial infections, and you listen to their chest and they have unequal breath sounds, you have to ask if they've been tested for cystic fibrosis. Because it doesn't, we saw with the bronchiolitis slide, that's not necessarily symmetrical, but the microbes, we breathe the microbes in, they go through all the respiratory tree, the whole respiratory tree responds, right? That's not necessarily the case with cystic fibrosis. Make sense to you guys? Okay. So nutrition, these poor people burn a crap load of ATP trying to breathe. Okay? So they're constantly facing nutritional deficits. So you let them eat whatever the hell they can eat. And a lot of times you increase their fat content, and why? But Jim, that might cause cardiovascular disease. They probably won't live long enough to develop cardiovascular disease. And there's a lot more energy in a fat molecule than there's anything else. Okay? So, I don't care about this stuff. The gold standard for testing is the sweat test. Okay? So, what do you see if you see sky-high sodium and chloride finding in sweat? That is the way, and then you look for the gene. Okay? Why? They can't get, they don't have chloride channels. They can't get the stupid chloride in, or the sodium, because of the chloride relation. So it stays extracellularly, and so they sweat it out instead of allowing it to go in so that water can follow. Does that make sense to you guys? Okay. Treatment, well, you do whatever the hell you have to physically dislodge the mucus. Yeah, Brianna?
How do they test your sweat?
Oh, there's a bunch of different ways to test the sweat. I have a friend who went, not for that, but who went for, they had to gather sweat for something else. So what they did, and I'm not kidding you, you guys are probably all, most of you way too old to know who Richard Simmons is. But, yeah, so they put on at this physician's office, they put on Richard Simmons' video. That's traumatizing, okay? And they actually had the patient imitate what Richard Simmons was doing for about 10 minutes. And lo and behold, they had a positive finding for something. So, I mean, there's a bunch of different ways to do the sweat test. You give flu vaccines, it's immunization season, guys. Get the flu vaccine, okay? And actually, I think we had it on campus for free, right? Recently. There's a bunch of places you can get it for free, all right? All right, talk about that. All right, let's take a very short break, like 3 minutes, 4 minutes. Here we are, I'm going to start. Okay? We have to. Yeah. I remember. Yeah. It's extremely, yes. Oh, yeah, exactly. What was that? No, it's actually the people who have cystic fibrosis, one of the big complaints is, it hurts like hell. And, you know, I mean, humans are pretty amazing. These poor people are irrelevant. They're failing disease. Hey, Chris.
We make you want to talk.
You have to hold it in.
Just like
You know?
it's gonna give us heart problems, okay?
Yeah, exactly. It's good.
Subconsciously. We start blowing up.
That's good. I'm not looking.
You didn't chat?
No. I know. We're against a mobile quarterback. Gronk isn't playing.
Neither good or bad.
It's neither good or bad. Okay, Kira, I'm holding you today. Okay. What I was actually really interested in was to see how the Yankees are doing. Yeah, I know. So. Right. Right. That's awesome. That's okay. Wow. Right. I appreciate that. Sure. I mean, all I can do is to move back and forth as you should. So I'm not global statement, but and that's stuff, but it's just like really. Right. Exactly. And so I'm so
That's all right, I understand.
yeah.
Yes, you're gonna go for it. Yeah, me too. Did you what? You're not in this, you're gonna send it. Come out with it.
Yeah, it's
Then you can add some like, there's marking. There's no marking. There's a marking. Don't worry.
It must be something.
The average. This is the big
All right, but we're starting up again. All right, so acute tracheobronchial obstruction. What does that mean? You got something, you aspirate something, okay? Like what? A piece of steak at Longhorns, because Americans always chew their food thoroughly, right? And never talk while drinking or chewing food. So usually it most often falls in the right lung. Is that right? Yes? Mr. EMT, is that right? Oh yeah. What do you guys have anything in your notes?
Yeah.
What did it say? Right, and that's wrong. It's right lung. Why? It's the way it's anatomically structured, that's why. Okay? The left lung, 2 lobes, the right lung, 3 lobes. So get rid of left, scratch that out. It's wrong.
It'll warn us before
Yeah, exactly. And I apologize. I am, so for whatever it's worth, Kara, it's true. I really am dyslexic. So it seemed like it was left because I was thinking and viewing the patient. So
That's a good one.
So, I got a whole list of those excuses. No, for real. So it's the right lung, okay? So you aspirate something. What's another reason? A malpositioned endotracheal tube. Yikes. That doesn't happen too often in Albuquerque. Let's not talk about that. Can that kill somebody? You bet it can. And then the people come out and explain, they had an allergic response to the tube. Sorry, that's BS. Okay? Laryngospasm. So, spasming. There's a bunch of things that can cause laryngospasm. If you have woken up in the middle of the night and you can feel your larynx is spasming and you can't breathe and it goes away, please go get that checked. Get the endoscopy to determine, do you have GERD? Do you have esophageal varices? Do you have some process that's going on? Because eventually one day if you don't address the trigger, it might spasm just a wee bit longer than what's good for you, okay? Epiglottitis, we're gonna talk about epiglottitis. Trauma, obviously, smoke inhalation, that's a big thing. Somebody's been in a building or a car where there's been intense heat or the smoke that comes from the fire, and actually, the guys and the women that go up and do forest fire remediation, if they're not careful, they don't wear their gear, all the other stuff, what happens is you can get the trachea to get so inflamed you're not able to you can't intubate them and they die, okay? So, how do you know somebody has a partial obstruction? You guys, they're going, they're talking to you, or they're going, right? Can't breathe. You might have wheezing, nasal flaring. Listen, guys, think conceptually. It's obvious when somebody has something that went down the wrong way, right? Okay. Complete obstruction. I love this. No air movement, hurt with auscultation. The one thing you don't actually really give a crap about is the, oh, you know, I don't hear any air sounds, right? Okay, exactly. Inability to talk, etc. We can't go without oxygen for any real length of time. So you aspirate something, it's not unusual for the person to pass out pretty quickly, okay? All right, diagnosis, I think it's self-evident, I'm not going to talk about that stuff. What's the point? Do Heimlich maneuver. Hey, that's not working. Suction. Hey, that's not working. Tracheostomy. But you have to know where the hell, you have a pretty good idea of where the hell the obstruction's at before you do that. Okay? Epiglottitis. So listen, kids are smaller, right? Especially if they have microbes. But kids are smaller, and that means the tubes are smaller. So if there's an inflammation, the inflammation, if it's serious, can have a much more serious and a much quicker adverse impact on a kid than it can on an adult. So what is epiglottitis? It's inflammation of the tissue, the soft tissue that makes up the epiglottis, okay? Not the cartilage. So some kid gets pneumonia or strep, and the legal guardian doesn't take them to see a healthcare provider. And I'm telling you guys, you will see this in this state frequently. Depends where you work, okay? As a matter of fact, a study is going to be published soon, soon in a year, probably. The way we care for, on average, the way the average Mexican cares for a kid is actually pretty crappy. And so you guys will see this. So they get strep throat, they don't get taken to a healthcare provider. The strep, seeds the pharynx and the larynx. And it gets over into the epiglottis. And the epiglottis, or they don't get the flu vaccine, or whatever, and the epiglottis gets inflamed. Well, here's the problem. If the epiglottis gets inflamed, so look, this side right here is the anterior of our pediatric patient, okay? This side's their back, posterior. My knuckles, my hand, that's the kid's trachea. This is the epiglottis, my thumb. It gets inflamed, it gets inflamed, it gets inflamed, it's covering the trachea. That's a medical emergency. Make sense to you guys? Okay. So, if you have a kid that's under 2, and you have, I'm not being a jerk when I say this, okay? I'm talking strictly clinical experience stuff. And you have a legal guardian or two who have not invested time with that child, teaching them to read, teaching them to speak, and the child has a limited vocabulary. Well, all kids have a limited vocabulary under age 2. Not true. It just depends how much you invest in the kid. Okay? Well, kids are meant to be kids. Okay, we beg to differ. The sooner you equip a kid, the better they're going to be able to navigate their world. Okay? And speak up, or understand how to answer questions in the emergency room. So you have a kid who's 2 or under and not an established vocabulary, and the only thing they can do is like make signs, but they're jonesing because they can't breathe. They don't understand. They're scared. They might be drooling. Okay. Obviously, if they have some airspace still open, they might be able to verbalize something or make sound. They might only be able to make grunts, right? They're not, I don't understand. They're not eating, I put food in front of them, what the hell? They're not eating. But I've seen it all, okay? So listen, you schmuck, you didn't notice that the kid's not breathing? So one of the things that they do, I'm serious, they don't actually think about this. They go into the position, they do the dog sniff. They get on all fours and lay on their bellies, and they're like this. And the reason why is that's the only way they can get any clearance into the trachea to get air. Now you ask yourself, this doesn't develop in the course of several hours. It doesn't. That's the point. Okay? So, classic X-ray sign, thumbprint sign. Swollen, inflamed epiglottis, can't miss it. Okay? It's a medical emergency and it's got to be taken care of right away. So it may necessitate innovation. So when I first went to medical school, the answer was, well, okay, why don't you just intubate the patient, right? You're learning things and you don't really understand what those words mean. So we're hesitant always to intubate anybody for many reasons. One, you don't want to do harm to the trachea. Two, you want hopefully to have a patient that is easily extubated so that they can not be dependent on the tube. But with kids, they've got narrow little tracheas, and the likelihood of doing serious damage is sky high. Okay? So, how can you prevent a kid from getting epiglottitis? Make sure they have their stupid immunizations. Okay? And when they have a sore throat, take it seriously. Period. That's it. It's easy. Okay? Croup. So, it's not one disease. That's the weird thing. So I like to test on that, just FYI. It's not one disease. So what's the deal with croup? It's a bunch of diseases, viral. And can you get epiglottitis if it's not taken care of? Hell yeah, you can. Okay? When does it happen? Fall and early winter. Why? Because parents are then, or legal guardians are then going back to doing what they're doing, and kids go to daycare. Right? Make sense? But it's not just the daycare crowd that can get it, but that tends to get it. Okay? So a bunch of different microbes, viruses can cause it. You can get epiglottitis. So what is croup? It's unmistakable. It's a barking cough. Okay? Now, I am here to tell you that croup and whooping cough, we literally we're going to probably, although actually because of all the rain, we're not seeing a super spike, but last year, the year before, I've been in the state for almost 12 years, every single fall time, by the end of the year, you read in the Albuquerque Journal and in the CDC's epidemiological data for the year here that we've had another regional epidemic in whooping cough and in croup. Why? Anybody? No immunizations. It's not a financial reason because you can get those for free. Almost everywhere, you get them for free here. Well, because the legal guardians have some moral, Facebook, internet kind of knowledge about these things, and they occasionally smoke weed. That, Jim, you're being morally judgmental. I'm actually talking about data that I see every year from the CDC because I actually crunch numbers for them here. Okay? Now, it's not my opinion. I'm telling you what we have. Here in Albuquerque, in Las Cruces, up in Santa Fe. All right? So, what's the deal? Listen, when you're coughing and coughing and coughing and coughing, it's hard to catch your breath to get air in, right? You're also, when you're coughing, you're creating a temporary obstruction, so air starts to get trapped in because you're irritating the airways and there's inflammation. Does that make sense, everybody? All right. So, don't care about that. How do you treat it? Mist therapy. So again, Jim, do I buy the warm air humidifier? Please don't ask me these questions. Okay, do whatever the hell floats your boat. Showers are cool. Cool mist is a nice thing. Just saying. Bacteria, warm water. That sounds gross to me. Oral hydration, of course. Why oral hydration? Because it helps to clear out stuff, and it helps to make more dilute any mucus that might be forming in the respiratory tree. Avoidance of stimulation. So you've got a little kid, the last or a neonate that gets croup. You don't want to be handling the kid. Why? Because they're irritable. If they're irritable, they're going to cry. If they're going to cry, they're gasping for air, right? Okay. Nebulized epinephrine, I will tell you that, if you have to, you do it. But nebulized epinephrine makes the heart race and the blood pressure goes up, and you have to actually let the parents know that it's possible that Junior may have all kinds of weird chest palpitations and high blood pressure for several days after you do the nebulized epi. And then endotracheal intubation. Can somebody go into respiratory failure with croup? Sadly, yes. Okay, you're coughing enough, obviously you're losing the ability to do VO2-CO2 exchange. Pulmonary function test, I don't give a damn. I do care about this though. So if somebody's FEV sub 1 over FVC is greater than 75%, what does that mean? They might have an obstruction, but it's not a significant obstruction. Jim, it's greater than 75%. Remember, what did we say is healthy, buddy? Right? Okay. So when you get to 60 to 70% mild obstruction, I want you to know this slide, I guess is what I'm saying. Okay? Greater than 75, probably nothing, or easily managed. Between 60 and 70, a mild obstruction. 50 to 60, it's a moderate, and if it's under 50, that's a severe obstruction. Don't care about this slide. I do also care about this slide very much. So, how do you know somebody has a obstructive pulmonary disorder? Now, they may not have asthma. So listen, don't misunderstand what the slide says. This isn't only for asthma. So somebody comes in and they blow in the spirometer. They get some result. What you do is you sit them down, you give them the extender, you give them a hit of, you teach them how to do it, you model it, and they take a hit of the Ventolin or whatever, salbutamol, whatever the hell it is that they that particular office has. And you let them sit down for 15 to 20 minutes peacefully, non-agitatedly. So those of you who use these babies, yeah, it can take up to 15 or 20 minutes to actually get your airway to open. So if you don't get the result right away, you go just keep on pumping, right? That could be dangerous. But if you have to use it, you use it. And if you have to pump, you pump, because you know your lungs. So I waive all liability for everything I said. So what you do is, so the person comes back and then they blow again. If the spirometry results are, if there's an increase in their FEV sub 1 of greater than 15%, that's a positive diagnosis. They have an obstructive pulmonary disorder. Then you have to go find what it is. Does that make sense to everybody? So this is not, do they do this for asthmatics? Yes. But for all people who have obstructive pulmonary disorders. You with me? Okay. Don't care about that. Don't care about that. Don't care about that. Just look at the COPD category, guys. Not what I tested you on the what I talked about in the PowerPoint slides, what you have to know. You don't have to know this slide. But COPD, I'm telling you, man, it's permanently, physically restructure your lungs. Every time you light up, that's what you're doing. Okay? So, don't care about that. Yeah, don't care about those.